It's my pleasure now to introduce you to the other panelists of this morning. We have two head and neck surgeons here. Hiltrud Glanz, she's chair of the head and neck surgeon in Gießen in Germany, and Carrie Olson, who is the chair of the head and neck department in the Mayo Clinic in Rochester. And I think you all know K.Kian, who is from the MD Anderson Cancer Center Head and Neck Service and former president of the ASTRO in Houston. So we have a very distinguished round, I think, which can really debate very clearly on all the subjects which we have in front of us. And the first thing I a little bit want to know what your opinions are here is for oropharyngeal cancer, early disease. Do you think there is a role for chemoradiation or radiation at all, or do you think it's purely a role for the head and neck surgeon? And first of all, I would like to ask Hiltrud Glanz.
When you have early disease, it depends if you have a local circumscript disease or if you have a superficial spreading field cancerization. I think you should have to take this in mind when you choose the mode of therapy. For the isolated, I would prefer without mutilating, mutilation after resection. I would prefer the surgical excision and the local control also surgically first of the regional lymph nodes by elective neck dissection if there is an N0 neck. Or even if I would ask the pathologist or have a look myself, because I did a lot of pathology, so I have a little bit more optical view on the structure of the lesion. If it's well differentiated and you have well differentiated borders, pushing borders, even if it's a T1 lesion, I even would think about not looking for the regional neck. But if you have a superficial spreading field cancerization, or even you have it here and there, then I think I would go to, and you have mutilation after surgical therapy, I think I would go to radiotherapy with concomitant or in discussion with the radio-oncologist, non-concomitant chemotherapy. You have to have several options. You heard about the four most still used therapies. So I think that the surgery alone is still an option, and I can show our results if you want.
Yeah, why
yes.
not?
And can you give my slides, please? Can you? Yes. And the next, please. This is just some numbers of unicentric retrospective study for a period of 15 years. You have seen about from 783 patients we had to exclude patients, and I want to show you oropharynx and hypopharynx, because what we just have heard is the same in our number of patients. Would you please go to the next one? Thank you. As you have seen, we do surgery in a very selected number of cases. Very selected, just what I have told you. And the biggest number is still surgery with radiotherapy, and in the last half of this period, concomitant chemoradiotherapy postoperatively. And then we have still a series of radiotherapy alone for especially for patients who are not able to undergo chemoradiotherapy. And we have about the same number of primary chemoradiotherapy. Concerning the method of chemoradiotherapy, we were working with the Munich protocol first, and then with the Berlin protocol. Everybody knows the difference, and it's marked there. The next. These are the numbers, and I wanted to just to emphasize what you heard from Dr. Vermoken, that there is a big difference between the oropharynx and the hypopharynx. You can see, in comparison to radiotherapy alone, you have a much better, conspicuously better outcome with concomitant chemoradiotherapy, and either with the Munich or the Berlin protocol. We participated in the multi-center randomized study of Professor Wendt with the Munich protocol, and when you compare it to the hypopharynx, there is a real big difference between these two lesions. But still, in selected cases, surgery is the best one for the patient's outcome and quality of life, as well for the oncological reasons. And then still radiation surgery, primary surgery with radiotherapy has very good outcome as well. And when it comes to the side effects of grade 3 toxic effects of after concomitant chemoradiotherapy, this is much higher than with radiotherapy or respectively surgery alone, and in combination surgery and radiotherapy. We are looking more and more on persistent and progressive ulceration into the depths of the soft tissues of the neck, long-lasting severe dysphagia, as well as airway obstructing edema, and demanding UCI interventions. And I just want to show you two examples. This is a hypopharyngeal tumor. The vocal cord was mobile before treatment, and this is a fixed vocal fold after treatment. This lady had to, and this is 1 year after chemoradiotherapy, and this is oropharyngeal ulceration, progressive ulceration, and in a stage 4 oropharyngeal cancer, and with involving the entrance of the larynx. The patient is still living, but the ulceration now is progressing to the carotid artery, so I'm just waiting for blow-up bleeding, and you can't do anything as a surgeon. And to have surgery after radiochemotherapy will be very limited, for my opinion. So it's the first and the last therapeutic option, and you have to have this in mind when you do this. Whereas surgery, you can repeat if it's possible, if the functional outcome, the oncological and functional outcome would be sufficient, and also concerning quality of life of the patient. And the last slide just summarize up what we think today. And we are looking forward to have other options which are taking into concern also the cancerogenesis by the HPV and so on. Thank you very much.
Thank you very much, Professor Glanz. I want to focus now on the early stage disease. The other aspects of we can discuss later on. So, Gary, what is your opinion on the early stage with respect to surgery and other modalities?
You know, when we look at any cancer of the head and neck area, oropharynx or oral cavity or any area, and we look at that specific question, I think that my basic approach is that it's very critically important that we always individualize our treatment for all of our patients. Because we look at the factors that go into the decision on what should you do for an early cancer, and I'm assuming if you mean early cancer, if we're looking just at T-stage, T1 or T2 at the primary site, obviously there are patient factors that are very important, the age, the health of the patient, comorbidity, prior treatment. There's tumor factors that are extremely important, the tumor type, the tumor extent, the tumor behavior within that individual, how it's growing or behaving. And finally, there's the treating physician's factors. And I think this is one of my biggest concerns of all as we look at oropharyngeal cancer, because as I travel around the United States, I can tell you that more and more places that I visit and I ask people about how they treat early oropharyngeal cancer, I can tell you that fellowship-trained individuals, many individuals at many centers, they don't even know how to take out oropharyngeal cancers anymore because they don't do it. Or they tell me they've never seen them. And I say, well, what do you do when they recur? And they say, well, we don't do anything. The patient usually dies. And this is a real concern because I think one of the things that we've been led astray, at least in the United States, not so much in the rest of the world, is this issue pertinent to what is the issue of organ preservation. And I would have to say that I think that we really have to critically sit back and say, what are we preserving when we preserve a tonsil or half of a tongue base? To take out a tonsil or a tongue base should give the patient normal function, no inability to have troubles with eating or swallowing, and a good oncologic result and a good functional result. Now, one can talk a lot about efficacy, tumor behavior, tumor issues, but in my opinion, if we look consistently at the world's literature, consistently at the literature at our institution, the people who did the very best in terms of their outcomes, both functionally and oncologically, were ones that had some combination of surgery and appropriate postoperative radiation therapy dependent upon the histologic findings. The other major factor we're losing is we lose the ability to even consider doing surgical treatment for tonsil cancers or tongue-based tumors, is we lose all the information that one gains at the time of an operation pertinent to the primary lesion. Is there lymphatic or vascular invasion? Is there perineural invasion? We lose all the information pertinent to the tumor type in the neck. What is the status of the neck nodes? Right now we know there's a tremendous capability and findings to upgrade and upstage tumors based upon radiographic studies right now, and we're seeing stage creep going throughout our field right now as people are treated strictly on the basis of PET scan and other imaging studies. And we know that as we go back and we operate on these people, many of those positive PETs are really negative. And in actuality, they would not be that highest stage. And so we're looking at a big influence on stage creep that's going along. So if we wanted to say, how are we going to study these tumors, even for the purposes of tumor banking? Are we going to be able to bank normal tissue, primary tumor tissue, nodal tissue to do further studies? We're losing that if we abandon a very realistic surgical approach to taking out the tonsil or tongue base. So for early lesions, I think that if there is no contraindications in terms of a patient's health, if there's no contraindications in terms of tumor factors or other things I mentioned, being able to go in and remove a primary tumor transorally, and we do these either with, and I don't get into the argument about what is the tool, whether one uses a laser or uses a cautery or uses robotic surgery. I mean, we're using robotic surgery a lot now. We've done over 50 cases of robotic surgery for oropharyngeal cancer, many, many more for lasers or cauteries. I don't think the tool is important, but when you can consider that you can do a primary removal of up to half of the tongue base, the tonsil, do an appropriate neck dissection, in most cases have the patient out of the hospital in 2 to 3 days, I think you're talking about something for which there's low morbidity and getting good information to be able to decide when should you add appropriate postoperative radiation treatment based upon primary findings and neck findings. For more extensive tumors, for tumors where I feel that there is clearly going to be an impact on function, those are individuals that I always want to consider having chemo and radiation therapy done. Because if I think that the patient is going to have significant impact on their function, that's the time that I think that we are truly trying to do the best thing in terms of trying to preserve function. But I can tell you that in the vast majority of patients that I see right now who have tonsil or tongue-based tumors, most of them do not involve a significant portion of the palate. Most of them do not involve the mandible. Very few of them cross the midline and involve the other side of the tongue or both hypoglossal nerves. Very few involve the larynx or extend deep into the parapharynx against the carotid artery. So most of these are very